Welcome to the International Isoprinosine Symposium and the closing ceremony of the 2024 National Obstetrics and Gynecology Congress. I'd like to start with a big hand for all the guests who are here with us, because we have thought about each and every detail of what you can see here for you. We have extraordinary presenters, a delicious dinner, the band Corporación that's going to get us to dance and have fun, and as the night goes by we'll have other surprises and gifts for you. To begin tonight, we'll give the floor to Dr. Angie Mora Calderon, who is the president of the board of directors of the Association of Gynecology and Obstetrics of Costa Rica. Big hand for her. Welcome, Doctor. Thank you very much. Once again, we are gathered here during this special night for the closing ceremony of this activity that has had us gathered here throughout the week. We are very tired, but we're also really satisfied with all the learning, with the sharing. It has definitely been a week where we have managed to make progress with small and big objectives, with very specific objectives, as well as needs that as a gynecological and obstetrics community we have managed to conduct as the professionals that are all here. And without further ado, I hope you really enjoy the conferences we'll have here tonight, as well as the closing ceremony that has been gifted to us or sponsored by Newport, by the company Newport, so kindly. On my behalf, as well as the board of directors of the Gynecology and Obstetrics Association of Costa Rica, I'd like to thank you very much for being here, and I hope you have a great evening. Thank you very much, Doctor. Now I'd like to have a very special guest join us. She is Tamara Razon, who is Medical Director of Newport Pharmaceuticals International. You're so elegant, Doctor. Wow. Well, good evening, everyone. This is a very special night. We are really excited and we're really satisfied to welcome all of the people present here. We'd like to thank the Association of Obstetrics and Gynecology once again for holding this International Isoprinosine Symposium. We'd also like to thank our presenters tonight from the Czech Republic, Dr. Jiří Beran. From Panama, Dr. Alfredo Beitia. From El Salvador, Dr. Edward Herrera. And from Costa Rica, Dr. Pilar Navas. We'd also like to highlight the fact that the Board of Directors of Newport Pharmaceutical has always provided support for continuous medical education. We believe in all of these activities that we hold for all doctors as well as those who accompany them, and we have Ana Cecilia Cantillo with us tonight, as well as Mr. Alvaro Garcia, who have allowed us to hold this great event. We'd also like to thank all of the delegations. The delegations are from Panama, here present. Great. El Salvador, also present. Ecuador. Honduras. Wow. Nicaragua. And, well, the whole of Costa Rica. It's also something that fills me with joy and satisfaction to welcome you all I hope you enjoy this academic activity, and I hope you also enjoy and celebrate life. Thank you, everyone. Wow, Doctor, you should be a host. That was great. I'm speechless. Beautiful family. He is a doctor and epidemiologist and a researcher from the Czech Republic. He's head of department of the Institute for Postgraduate Health Education in Prague, the Czech Republic. And he is also head of department for tropical travel medicine and immunization. Please, a big hand for Dr. Jerry Baran.
Good evening, ladies and gentlemen. Thank you very much for inviting me and for the possibility to be here in such a beautiful country I have never visited before. And today evening I would like to discuss well-known drug Isoprinosine and its effect we call immunomodulation. Don't be worried. I will speak about immunology and immune system, and I know that the majority of doctors hate immunity because it's a difficult branch of medicine, but I will try to explain everything slowly and in very simple way. In my disclosure, I would like to say that my presentation was supported by Newport Pharmaceutical International. My presentation consists from two parts. The first part will be about immunomodulation and isoprinosine. As you might know, immunomodulation is not the same as immunostimulation. It's some changes of immune system which are beneficial in defense against some viral infection. During the second part, I would like to discuss isoprinosine and treatment of different viral infections, including acute viral respiratory infections, COVID-19, and also some other infections we will discuss. Let's go to the first task, which is immunomodulation. And isoprinosine is immunomodulatory drug which is approved in several countries to treat viral infections under different conditions. Isoprinosine is also used for improvement of immunity which can be damaged, and it's especially a drug for improvement of cellular immunity. Isoprinosine is a drug which is known and used more than half century. It's a very long time, and it's available and licensed in more than 70 countries. In some of them, it's available as a OTC, but in majority, including countries, representatives who are today here, is as a prescription drug. There are three modes which can modulate our immune system via isoprinosine. It is lymphocyte proliferation, cytokine production, especially Th1 cytokine production, and cytotoxicity, especially provided by NK cells and cytotoxic T lymphocytes. Those three lines are difficult to understand. What is it? Lymphoproliferation in simple wording means that number of lymphocytes is going up. Th1 cytokine production means that immune system is supported cellular immunity. And cytotoxicity which is done by two specific cells, NK cells, so-called nature killers, are cells together. Nature killers is cell which is part of innate immunity, and cytotoxic T lymphocyte is a lymphocyte which belongs to adaptive immunity. But both lymphocytes are armed with two important enzymes. The first one is perforin. When those cells, I mean NK cells or cytotoxic T lymphocytes, see some cell in your body which is infected by virus, they attach it, they do a whole via first enzyme, and using second enzyme, they destroy the cell. This is the most effective way how to prevent large infection in your body, to destroy it just inside of the cells. We learned about effect of isoprinosine from two very important researchers. It was done, both were done in UK. The first one was done at University of Birmingham. What they observed, they apply to volunteers isoprinosine, and after 90 minutes they see increase of NK cells. So after 90 minutes of using of the first tablet, you could see increase of NK cells which can protect you against viral infection. What they saw afterwards was increasing on double level at day 5 with maximum of NK cells which were armed with two important enzymes. This is very nice if you realize that when you use first tablet, within a few minutes your protection is starting, and maximum of the effect is on day 5. This was very important, and it was published 2017. The second research was done at Institute of Medicine, Lord Nuffield Institute of Medicine, which is the most prestigious institution of Oxford University. At the time where this research was done at Lord Nuffield Institute of Medicine, the director of this institution, Professor Radcliffe, received a Nobel Prize. What they observed in Oxford, it's also very, very important. In Birmingham showed that if you take one tablet, your NK cells are going up. But in Oxford, they were focused on opposite side. They were focused on infected cell. And when into infected cell is coming isoprinosine, then this infected cells is providing on the surface so-called ligand. Anytime when cell is infected, it's putting on the top ligands which are showing I am infected cell. Please come somebody from the immune system and kill me. Those ligands are very important. When you are using isoprinosine, you have on infected cells much more ligands. So infected cells, when you are using isoprinosine, are much more visible for NK cells. So in summary of those two results of research, we can say that increasing number of NK cells and also increasing number of ligands are ways of immunomodulation of the immune system via isoprinosine, which can help you to resist against any severe viral infection. In this slide, you can see also NK cell, which is on the right side, and infected cell, which is on the left side, and you can see ligands, and you can see receptors on NK cells, and when they are putting together, then enzymes are released, I mean perforin and granzymes. Now we will go to the second part. So immunology is behind us, but I hope we will remember what immunomodulation means in terms of isoprinosine NK cells up and much more visibility of infected cells. Now we will focus on the treatment of the viral infections. And around a globe, there are at least 7 groups of viral infections which can be treated by isoprinosine. But majority of them are focusing on viral respiratory tract infections. Very popular treatment with isoprinosine is at human herpes virus infection and also for human papillomavirus infection. I will do a small stop at this human papillomavirus infection. Papillomavirus belongs to clever viruses. Clever virus is virus who is doing infection and who is going inside of cell and who do not provide any ligands on the top. So when HPV virus is going into body, it's not showing, I am here, please come and kill me. That's advantage. That's reason why HPV virus is source of cancer, because it's hidden for the immune system. There is only one type of cells which is able to recognize it. It's NK cells. NK cells, nature killers, are able to recognize HPV virus inside of the cells, even it's not providing on the top those ligands. On this picture, I think you saw this picture when you studied at medical school, but I think for some new information or repeating old information, I brought it. What you can see by blue line a virus which is detectable within few hours when infection starts. But you can see together with this virus, with this blue line, is coming also small gray line. And this gray line is line where NK cells and interferon are coming, so innate immunity immediately is coming and providing some type of protection. And afterwards is coming adaptive immunity. Adaptive immunity through cytotoxic T lymphocytes, which are able to do the same as NK cells, but only for the virus to which are trained. But NK cells are able to do it against any virus. And on the last way, antibodies are coming, firstly IgM or IgA, and afterwards IgG. For the treatment of viral infections, we could have a prevention. You know, many vaccines. Some of them are very successful, and those vaccines are vaccines against yellow fever, against hepatitis A, hepatitis B. Those vaccines are bringing lifelong protection. For the treatment, you can use symptomatic treatment, which is not causative treatment and which is providing just only treatment of the symptoms, or you can use antivirals and monoclonal antibodies. But for antivirals is the same for antibiotics. After a few weeks or months of using, you can see a resistance. Immunomodulation is a way which can improve even prevention and also the treatment as an additional treatment. Acute viral respiratory infections are the largest part of viral infections, which can burden very significantly human population, especially during winter months. It's a large group of viruses, and it's not necessary to remind you that influenza virus, parainfluenza virus, rhinovirus, adenovirus, coronaviruses belong to this group of viruses, and they could be with typical symptoms and also with some laboratory findings. What we know that it's very difficult to do in very short time diagnosis for influenza. So because it's expensive, it's very difficult to bring it into real practice like it was possible in COVID-19. But that's a reason why we are using so-called ILI, which is influenza-like infection, which is based on clinical symptoms. I would like to share data from study ISO 2014, which was done as double-blind placebo-controlled study as a prevention or using effectiveness of isoprinosine in prevention of acute viral respiratory infection. It was done according many gold standards, double-blind, randomized, placebo-controlled, in multicentric, multinational in 2 countries, Czech Republic and Slovakia. At that time, everybody who came to our centers with ILI, which was fever plus 1 respiratory symptom and 1 constitutional symptom, was randomized and received placebo or isoprinosine. They used those tablets. We were not able to distinguish. They used 2 tablets 3 times per day, and they use it for 7 days. What we observed faster time to resolution of influenza-like symptoms among people who were younger than 50 years and with no underlying chronic diseases. And as you can see, this change is on day 8. You can see this difference, which was statistically significant. And it was on day 8 because immune system requests some time for induction of all the processes which can help. Even we proved significant efficacy of isoprinosine. For me was also a very important result which showed a great safety profile of isoprinosine in the treatment of acute viral respiratory infections. Based on publication of Dr. Bulgakova, we also know how isoprinosine can help children with acute respiratory viral infection or pneumonia in children who have recurrent infection and who have underlying chronic diseases. For those children, isoprinosine reduced the severity and duration of symptoms, reduced recurrence and complications, and decreased a need for additional use of antibiotics. And in terms of pneumonia, it decreased duration of pneumonia and duration of hospitalization due to pneumonia. When they compare isoprinosine with rimantadine and placebo, they observed that the best is, again, isoprinosine. Rimantadine, just to remind you, is specific antiviral drug using for treatment of influenza. And isoprinosine contributed to faster recovery in clinical symptoms and reduction of hospital stay. As for COVID-19, I have to say a few words for COVID, which occupied our population for 4 years and which damaged a lot of social contacts, who put our children into addiction of electronic addiction, and which really was a negative impact on the population. What we can say about COVID-19, it's infection which is caused by SARS-CoV-2 virus, and which has approximately the same seasonal pattern as other viruses, but at the beginning there was some difference, slight difference in symptoms, but a huge difference in complication comparing to other acute viral respiratory symptoms. As for as symptoms, it was at the beginning, and you remember it, shortness of breath, a new loss of taste and smell, and nausea or vomiting were much more pathognomic for COVID-19. But the key complication which occur at COVID-19 and we observed among patients with severe course of COVID-19 during the first 2 years of this pandemic was viral immunosuppression. Viral immunosuppression, you cannot see it. Patients came to the hospital after 1 week and they had a severe lymphopenia. And lymphopenia was strongly related to death rate. And the second part of people who die for COVID-19 died because of venous thromboembolism, because virus was replicated inside of endothel. The third complication was secondary bacterial infections. From the beginning, it was pneumonia, and you remember last 2 years, it was sinusitis. At the time, we got information that at 3 nursing houses, they used isoprinosine by GP for elderly people who were positive for the virus. It was 142 subjects in 3 institutions, and we compared them with the rest of subjects who were positive in the Czech Republic in similar institutions, but who didn't receive isoprinosine. And we also compared them with approximately the same institutions in Ireland. What we observed case fatality rate which was a group of people who using isoprinosine, approximately 12%. Among people, rest of the Czech Republic was around 18%, and Ireland it was 25%. The most important is the difference at age cohort 75-85, where you can see a huge difference between elderly people at 3 institutions with red column comparing blue column of the Czech Republic. Here is odds ratio almost 3. What does it mean? Again, in simple wording, it means that senior who is institutionalized and who is using at the beginning of the COVID infection isoprinosine, his chance to survive is 3 times higher than senior who is not using this isoprinosine. Study with double-blind study, placebo control with isoprinosine was done in India. They enroll subjects who were positive, outpatient and hospitalized patient who were positive for SARS-CoV-2 virus. For everybody, they provide at the time treatment which was available, but only one group received isoprinosine. You can see again time to resolution of symptoms. The difference between 2 groups, isoprinosine and placebo, is about 17%, and when they selected just only outpatients because they received isoprinosine very early, the difference was almost 30%. Coming to other indications, I already discussed acute viral respiratory infections. For influenza, there is a significant reduction in symptoms and viral shedding. Herpes infections and genital warts, there is reduction of severity of symptoms and reduction of recurrence. And for panencephalitis, it improves neurological status, prolongs remission, and there is a higher survival rates. In the conclusion, we can say that isoprinosine is very good treatment option from clinical point of view. It's non-specific treatment, and it's very good for using for any viral infection. And isoprinosine can be used also for COVID-19 because it mitigates viral immunosuppression. And as I said, it's modulating immune system via NK cells and cytotoxic activities. For safety profile, it's not necessary, again, to underline that it's safe drug which is used more than half century without any safety issue from many clinical trials, and it's very good information. So isoprinosine is immunomodulatory drug with broad spectrum of antiviral properties, and it's used, or we can say it's well-established medicine. My last slide, and you are happy that this last slide is from the spicy market in India. And I think as much as necessary is spicy for cooking of good food, isoprinosine is necessary for good protection against viruses. Thank you very much for your attention.
Thank you, Doctor. Thank you very much.
Thank you, Doctor. A big hand for Dr. Jerry Brand. Thank you very much. So, where's everyone from El Salvador? There they are. Now we're going to call Dr. Edward Alexander Herrera up. He's a gynecologist and obstetrician from El Salvador. He is the president of the Association of Gynecology and Obstetrics of El Salvador. A big hand for him, please. Good evening. It is a real pleasure to be sharing the closing ceremony of this wonderful and successful event. I'd like to thank you all on behalf of the people of El Salvador, and after the brilliant presentation of Dr. Baran, I'm going to give you some small presentations regarding some particular uses of isoprinosine for specific pathologies in the area of gynecology. I will be specifically addressing the issue of isoprinosine for genital warts, which is a condition that has been described throughout history. And even though it doesn't produce any deaths, it does produce many problems amongst females and amongst the population in general when we look at the HPV virus and the way it affects us generally. We're talking about very serious problems like penile cancer, vulvar and vaginal cancer, as well as cervical cancer, which are real problems amongst our population. However, if we look at this pyramid for the virus, this is a 2017 study, and even though currently HPV immunization coverage in our countries has been widespread, or we're trying to make it widespread, the significance of the virus in terms of genital warts and, of course, in terms of the aplasia and dysplasia on a cervical level is still quite significant. We're talking about an important number of cases, and in many cases it's mainly due to shame or fear or lack of time that many women and men delay their visit to the doctor, which means that they reach considerable sizes, and then this requires multiple surgical procedures as well as long treatments. When we talk about isoprinosine, this is not a new molecule. The first few studies date back to the 70s, and we have seen, as Dr. Baran explained, that they have been used for different diseases such as subacute sclerosing panencephalitis, herpes simplex, HPV infections, and also for HIV, influenza, different acute respiratory infections, infections as a result of cytomegalovirus and the Epstein-Barr virus. On this occasion, we can look at some studies and how they've been used for genital warts, and we can observe a percentage of effectiveness when managing warts that ranges between 70 and 90%, depending on conditions. This does not mean that we will only administer isoprinosine. We will look at different tables regarding conventional management with isoprinosine as well as combined management, which is what really increases the effectiveness. When we look at the study where we are assessing the different ways of using isoprinosine, we are talking about effectiveness when comparing isoprinosine with conventional treatments, whether these are through fill-in, cryotherapy, electrocauterization, CO2 surgery, and then when we find that separate therapies have a relatively high degree of success, combined therapies with isoprinosine and conventional therapy greatly increase the percentage of people who get better, as well as the period of recurrence for this disease. This study concludes that the advantage of the oral or topical use over-hospitalization and anesthesia makes isoprinosine a really valid treatment for management of this type of condition. If we assess the treatment of cervical and vulvar condylomas with CO2 laser, we find that when we use the latter, we have a failure in treatment that amounts to 31.6%, and in patients with vulvovaginal condylomas, we have found a failure rate of 66.3% of cases after 3 laser treatments. There was 5.3% failure for cervical condyloma and 33.3% for vulvovaginal condylomas. And the group that was treated with plus isoprinosine only had 6.9% failure for cervical condylomas and 5.7% failures for vulvovaginal condylomas, with a treatment period that was of 3 cycles, and we practically cured the majority of patients completely. A couple of months ago, when I was invited to participate in this presentation, I was asked to look for a case that would serve as an example of the use of this kind of medication. This is the patient that we chose for this case. It's a 46-year-old patient with rheumatoid arthritis. She was treated with steroids, with prednisone and dexamethasone for 21 years, and she was fighting against the vulvar condyloma for 5 years. And this was really affecting her quality of life, as well as all the psychological aspects it included. We saw her for the first time on the 5th of April, and we proposed the possibility of treating her with isoprinosine. Naturally, as literature tells us, it's not only isoprinosine. We combined it with a conventional treatment, which is what we're going to look at when we see the next few slides. So another study with isoprinosine, and the majority of evidence can be found in Russia and neighboring countries, which took a little longer to reach us. But this is a multicentric study where they used 55 patients with genital warts, who had genital warts, and they had had this kind of problem for over a year. We used a 4-week cycle with anosine and Predibex, 3 grams a day, which was 1 gram 3 times a day. That was a dose. And we observed that the management with this kind of combination was highly effective. When we assessed it through a placebo and found that there was a better resolution amongst the patients, we saw that the result was not 100% effective. We will see this in some slides later. However, they did see that isoprinosine was an option to improve the evolution for these kind of patients. This is the patient that we included in the protocol 1 month after the initial consultation. This one took place on the 5th of May after the first cycle of isoprinosine, and I can tell you that the patient was happy when she arrived. She really felt a noteworthy impact in her life, and I was equally happy to see that she had eliminated this. Another study where we talk about the evidence of congenital warts of anosine and Predibex, where we assessed 155 heterosexual men and women who had warts and found that anosine and Predibex was more effective with longer duration lesions. The effect was much better the longer the patients used it, in other words. And then, if we combined it with a conventional treatment, that increased the rate of success from 41 to 94%, which is a basis upon which we can take this tool as part of our daily practice. Throughout this study, we observed a percentage of patients that were treated only with isoprinosine and others with conventional treatment only, and naturally the results were relative and were not as high as those we got when we observed a combination of treatments. This was the conclusion reached in the study. We assessed a total of 14 patients as part of a follow-up, and we found that when isoprinosine was used together with conventional treatment, whether this is podophyllin or the use of cryotherapy or electrocauterization, the percentage of success after a 3-month period is of around 95%. Naturally, this is really good for management purposes of our patients. What can be better than the satisfaction of seeing a patient who seems happy with the treatment? This is a patient who we saw after less than 2 months. Naturally, we'll continue with the treatment and we'll do a follow-up for a prolonged period of time. But there's really nothing more satisfying than to see a patient who is feeling happy and to feel empathy, to know that we can help each and every one of our patients, to know that we have a functional and effective tool in such a way that we can help to fight this kind of problem. As I was telling you after the brilliant presentation of Dr. Baran, our presentations are fairly short and specific. We really need to include isoprinosine within our work tools, and we know that they've been used for a long time for respiratory infections as well as other viral infections. But more and more this is becoming a crucial part of management for each and every one of our patients. So we'd like to thank you for your patience, and naturally, if anyone wishes to download the isoprinosine studies, you have the QR code right there. So this is really important evidence, as we were saying, not only for HPV, but also for pathologies related to viral infections. This is also very important. Thank you very much.
Fuerte el aplauso al doctor Edward Alexander Herrera.
A big hand for Edward Alexander Herrera from El Salvador. Thank you, doctor. We are now going to call our friend from Panama, Dr. Alfredo Beitia, who is a gynecologist and obstetrician, who has high studies in the Faculty of Medicine and specialty from the University of Panama. Welcome.
Contento de estar con ustedes compartiendo esta actividad.
I'm happy to be here with you to share this activity. I'd like to thank Newport Pharmaceutical for inviting me to share some experiences with you. They asked us to share them tonight, and I'm going to be relatively succinct about it. We're going to talk about the clinical utility or usefulness of isoprinosine for persistent HPV. Specifically, we know that HPV has a high possibility of producing cancer as long as it's persistent over time. It's not only HPV, it's the high-risk HPV. HPV infections have the ability to produce diseases like dysplasia, which could be mild, moderate, or severe, and this capacity can be checked through a colposcopy or biopsy. Tonight, to show an example of what I'm trying to explain, I'll use a clinical case, which is what we see normally during our colposcopy and cervical pathology consultations. We have a 39-year-old patient. She had 2 pregnancies, 2 deliveries, non-smoker, and we planned a salpingectomy, and then we conducted a liquid-based cytology, and we found inflammatory malign cells. We conducted an HPV DNA for high risk, and it resulted in a negative HIV. She also was not immunocompromised according to her medical history. So how would you manage a case involving this patient, if you know that we have high risk HPV? Do we go with reflex cytology? Do we repeat PAP or co-test after a year? Or do we schedule a colposcopy and a biopsy? So do we go for a colposcopy? Yes, that's what we're going to do. 39 years old, 2 pregnancies, 2 deliveries, and this is what we found. So there's a large lesion, 2 quadrants, and we have a mosaic here. You can barely see the border in the endocervical canal, but it's a large lesion. So what would your colposcopic impression be for this patient? We tested her. Naturally, we saw the same lesion, and according to the characteristics, would it be normal? Would it be a low lesion or a high degree lesion? Is it an intraepithelial lesion of a high degree? Could it be cancer? So it's a high degree lesion, and naturally when we found this with the imaging, we conducted the biopsy. We found a high degree lesion, so we scheduled a leap cone in January of this year, in 2024, which reported a carcinoma in situ with a glandular extension with clean borders, and we also observed endocervical polyps, and we conducted a resection. So what would be the risk of recurrence or persistence of CIN for this patient after the cone performed in January? Is it 50%, 75%, 5 to 27%, or no possibility of recurrence or persistence? Give or take, what is it, 0? C, perfect, yes, 5 to 27%, that's right. No matter how good the cone we perform is, there's still a possibility of persistence or recurrence over time, especially after the first 2 years of the treatment. That's why these patients need a follow-up for over 25 years. 24 years, they need to be our patients, given the residual possibilities of the disease in the future and the persistence. The incidence after the first leap is more or less 27%, but look at the predicting factors that can lead this persistence. We have CIN positive borders, we have previous lesions, disease in multiple quadrants, HPV infection, there's a higher risk, especially 16, one of the most frequent in this case. We also have a patient who's immunocommitted or compromised. The patient has used chronic corticoids and substances to treat cancer or multiple myelomas, and we have more and more patients with immunosuppression and patients who are older than 50. And in the endocervical canal, we have determined that it's difficult to manage and treat this patient, so we have recommendations for CIN management which are not clear at this point, but we have observed recently that HPV is a predictor for persistence or recurrence after LEAP because of its ability to check persistence after 6 months, which amounts to 93%. There's a specificity of up to 85%, and if the test is negative, the predictive negative value is approximately 99%. So what does that mean? Well, 6 months after the cone, we classified it, and I'm almost certain that there's very little likelihood of persistence or recurrence. that's why this test is so reliable. So we check this woman 6 months after the leap and look at the comparison. If we look at regarding January, what is the possibility of recurrence or persistence of the CIN at this point? Well, we talked about the positive borders, but it wasn't the case. There were clean borders, no glandular lesions. We talked about disease in multiple quadrants. We can talk about HPV at 16, but it wasn't 16. So there was no immunosuppression. She was no older than 50. And there was CIN grade 3, if we look at the histologic grade. But these are the risk factors that could lead to persistence or recurrence over time. So she could benefit from the use of immunomodulators that have proven the possibility to reduce the possibility of recurrence or persistence over time. So what would be the best management? So after 6 months, what would it be? Would it be a PAP, or colposcopy, a pap smear on its own, or an HPV test after 6 months? After everything I've said, naturally it's HPV, but if we have a PAP and colposcopy available, let's use it. If we don't have this classification, we need to verify that there are no residual diseases, and naturally a PAP and colposcopy are still valid at this point, and this is what happened. Approximately in 2016, there was a controversy about what we could do with this patient. And the American College of Gynecology were recommending cytology and colposcopy after 6 months, and if anything positive came up, colposcopy, biopsy, cone. In 2012, they recommended a co-test for classification purposes every year, and if anything came up positive, we have to assess the patient again and verify the persistence or recurrence. However, recently, the American College of Colposcopy and Cervical Pathology recommended that after a leap cone for a patient, you conduct an HPV test after 6 months, and if it's negative, after a year, and then if it's negative after 3 consecutive years, then we need to continue with the follow-up for this patient for at least 25 years, given the likelihood of persistence or recurrence. So what role does immunotherapy through adenosine and Prodobex play for patients with HPV? Let's try to resolve this specific matter. After checking different studies, we can see evidence regarding therapy with adenosine and Prodobex, which shows clinical effectiveness to stimulate the innate ability of the patient and to strengthen the immune system of the host and to promote the elimination of cervical HPV, which means that the possibilities of recurrence and persistence over time will diminish or will be eliminated. And there are revisions. Dr. Edward has talked about several studies where we look at follow-up of medication over time for treatment of genital warts in the lower region. This works really well. But there's this study conducted in Bulgaria where they have been using medication to assess the persistence or recurrence after treatment. This was used in 2020 by Dr. Kovachev in Bulgaria. One group used isoprinosine, another group didn't use any medication, and after a while they used a leap cone. After the second year there was no significant year, but after the fourth year, the group that used isoprinosine had a much lower rate of persistence amongst that group, and it was statistically significant. So, to summarize it all, we currently have evidence to show advantages because we have observed the ability to reduce the viral charge of isoprinosine, and the improvement of symptoms is important, and therefore this medication has an acceptable security profile and it's tolerated when taken orally by the patients. And if you look at the costs, they're also quite acceptable, and definitely for this kind of patient where you find precancerous CIN3 lesions or higher, that needs medication to reduce the possibility of recurrence and persistence over the next 20 years, will definitely be used by this patient. It's well tolerated, it's safe, it's as old as I am, and we've been using it over the last few years. We can recommend that isoprinosine is considered as a promising therapeutic option for complementary treatment of resistance of HPV. Thank you very much.
Muchísimas gracias, doctor Alfredo Beitia.
Thank you very much, Dr. Alfredo Beitia. I'd now like to call Dr. Maria del Pilar Navas to come up. She's a specialist in gynecology and obstetrics from the University of Costa Rica. Welcome, doctor. It's a pleasure. Good evening. This is the last conference before we start with the party for everyone. And we're very quickly going to talk about the point when immunosenescence intervenes in HPV. I don't have any conflicts of interest. I have provided conferences for different labs. And we're going to start with the clinical case. We have a female patient, 54 years old, 2 pregnancies, 2 deliveries, 0 abortions. She became a widow 6 years ago, and she had a leap for a CIN2 at the age of 38. She has not had any sexual relationships since she became a widow. She annually has a gynecological checkup, and in 2024 she had an intraepithelial lesion of a low degree, CIN1, with cytocolpohistology and endocervical extension. At the end of the visit, she forgot to tell her gynecologist that in 2023 she was diagnosed with a rheumatoid arthritis, and she has been treated ever since. So this patient was going through a storm, through chaos. She didn't know what to do. The patient was not having sex. Her problem had taken place a long time ago, and currently there was a relapse. The patient was facing a mental cobweb or spider web. She was having a social, personal chaos in terms of having a couple, even though she didn't have one currently. She was having a family issues, she was having medical issues, and she didn't have insurance coverage for this kind of pathology. So what happens? When we have this kind of patient, we have to take our time for the patient to understand what it is that she's facing, to understand that there are many types of virus. Some of them have higher degrees of recidivism than others, some are more oncogenic than others, and there could be recidivism or multiple viruses for the same patient. So let's look at this, and that hopefully this will wake you up. Let's look at the following. We have loads of spider webs. They're all spider webs, and we have spiders there, small spiders. But notice they're not all the same. As you can see here, 2 of them are different. So what is the real problem? Well, it's that we don't know for what patients the virus will be eliminated and in which cases it will persist. So what does the WHO say regarding the persistence of the virus? What are the factors that, according to the WHO, will help the virus to persist? 1, oncogenicity. 2, the immune system or the immune status of the patient. This is the case for this patient because she started with an immune disease. 3, co-infection with other STDs. 4, smoking. 5, number of deliveries. 6, the early age for the first pregnancy. This is what the WHO say, and I added something which you don't see in this patient, but you can find it in some cases, which is sequential monogamy. This is when you have a patient And the patient says, yes, I'm with the same couple. The following year, they say, yes, I have the same couple. Except every year or periodically they change their partner. So I want to talk about immunosenescence. Immunosenescence is when our immune system is low, when we have changes in the immune system as a result of aging that affect us both in terms of innate immunity as well as adaptive immunity. Let's not forget that innate is the one that comes up first, lymphocytes B with antibodies, it's non-specific and fast, and the adaptive immunity is when we have lymphocytes lymphocytes T, those that are in a specific place, and we have different types of these lymphocytes, and these T lymphocytes are those that are going to act for a specific function that we need. So if we have immunosenescence, this is going to produce us or make us more prone to infectious diseases, to cancer, to autoimmunity, and even to a poor response after immunization. So what happens during this immunosenescence? There's dysregulation of T cells, which are the markers. The functional ability of these T cells is really influenced by aging. After birth, the thymus starts going through an involution. We start seeing a decrease of these lymphocytes. But through aging, as we age, we are going to be more prone to have other diseases because the system can diminish in effectiveness. So what happens as part of immunosenescence? Well, it affects the reduction of the relation of CD4 and CB8. So we have the CD4s, the helpers, the ones that cooperate, and the CD8s are the cytotoxic ones. So there's a lack of balance between them. There's a deteriorated development of the auxiliary follicle cells of the lymphocytes, and the transduction of the intracellular signals. There's a decrease when producing infective lymphokines. There's a deteriorated proliferation of this response, this antigenic response. And there are obstacles in our defense system or immune system. There are changes in the cytokines. There are more of them that are inflammatory in nature. So what's going to happen? We have inadequate or inappropriate immune response. And what happens with HPV? We need an appropriate immune response to be able to reach this self-clearing. So this is when we start with this product, Isoprinosine, as a double mechanism of action. It's antiviral on the one hand, and it works on the immune system on the other. It's antiviral because it's going to increase the synthesis of proteins and nucleic acids in the cells, and it's going to prevent viral replication, and it's immune because it's going to improve the T lymphocyte response from the T CD4s. It's going to support the natural killers and the B lymphocytes to create antibodies, and it's going to increase the immune humoral response. When we use metoprolol, it can decrease the intensity and over time the evolution of the disease, and it can create synergy with other medications. So it's a treatment that is a supplement for this other treatment that is going to help us. Metoprolol is going to be introduced into the infected lymphocytes, and it's going to inhibit the viral RN, and it's also going to include in the normal lymphocytes. It's going to block the reproduction of virions, and it's going to inhibit the RNA virus. So according to all the studies that we've been looking at, Isoprinosine is an immunomodulator, and together with the usual therapy for high or low degree intraepithelial lesions, it has very few side effects or no side effects, and it's going to help us reduce the recidivism. It's also a safe and effective medication. I do not want to conclude this without these next two slides, because we need to honor this man. Almost no one talks about him. Professor Harold Suhausen, who passed away in May last year. He's a scientist and German doctor who works in different parts of Germany, Bonn, Hamburg, Düsseldorf, who specializes in changes in virology. He won the Nobel Prize for Medicine and Physiology in 2008. And what is important about what he did? Well, those of us who are a little older recall when we were studying that cancer of the cervix was caused by genital herpes 2. I think many of us recall that. However, at the beginning of the 70s, this scientist started to say that he believed it was a virus that was behind this cancer of the cervix. No one believed him except his postgraduate students who started working with him. So he continued to work on this, and he placed a probe for HPV-1 for condyloma acuminatum, and that's when he found HPV-6. And he started using a probe for HPV-6 for laryngeal papilloma, and he found HPV-11. He took HPV-11 and placed it in tissue in the cervix through a probe, and he found HPV-16. And a year later, he found HPV-18 in cancer of the cervix, and the rest is history. So I think we should honor him, because prior to that, we had not started molecular biology, and since we didn't have it, people did not know. They continued to say that this was due to herpes virus until we started getting molecular biology with all the hybridization techniques, and we realized that it was really the papilloma virus. I would also like to recall the fact that, or remind everyone of the fact that we can have the virus, but we need some kind of viral integrity in the genome, and that's what's going to cause the infection. Because if I have the virus but it's not integrated, then it won't become a lesion in the cervix. So there's this competition between the immune system and the evasion mechanisms of HPV over time. And what are these evasion mechanisms? Microbiota, the transformation zone, and oncogenes, E6 and E7. And these oncogenes, E6 and E7, are going to inhibit apoptosis. By inhibiting cellular apoptosis, we're going to have more production of these precancerous or cancerous cells. So these are two very important concepts that we needed to remind everyone of. The start of molecular biology. In summary, the use of metosoprenol or isoprinosine for patients with HPV with lesions, cervical, vaginal lesions, and with condylomatosis of the vulva, the perineum, or anal condylomatosis. And we can also use this as a complement of the therapy that is offered, and we've proven that this is scientifically beneficial. We can use it as part of our therapeutic arsenal, and we can use it as part of the therapy that's offered to strengthen the immune system. Thank you very much. Thank you very much, Doctor. Please don't leave. Please stay up here. Let's also call Dr. Jerry Baran, Dr. Edward Alexander, as well as Dr. Alfredo Beitia. And the doctor was presenting just now. All presenters, please come forward. Thank you very much, Doctor. A big hand for all our presenters, all our lecturers tonight. Thank you very much, and naturally we're going to give them an award, some recognition.